All right, guys, it's great to be with all of you today. I really thank you for taking the time out to come and hear about global health radiology and the concept of bringing ultrasound to the point of care. Thanks for the introduction, Melanie. Thanks for all your help so far. I just wanted to start the talk by really addressing why we need this. Why are we doing this? So the World Health Organization estimates that 3 to 4 billion people, that's about half the world, have little or no access to radiology and imaging services, creating quite a huge disparity. A recent article published by The Lancet and Oncology created a simulation looking at how injecting treatment and imaging modalities into patient care would impact survival outcomes. Currently, in high-income countries, we have an average of 12 times higher than in low-income countries. And when you insert imaging, treatment, and other quality of care factors, you can improve that 5-year net survival we project by 10 times in low-income countries and double that in lower to middle-income countries. So really showing that things like ultrasound can have a significant impact in improving patient outcomes in the long term. Just some other disparities to address, just some statistics to look at. So in Tanzania, comparing 58 radiologists for 56 million people to Canada, for example, 6.9 radiologists per 100,000. Looking at breast cancer survival rates, looking at equipment types, 1 CT scanner for 1 million people in Africa versus 25 per 1 in US, Canada, and Europe. And when we look at ultrasound machines, pretty commonly we're seeing those all kinds, old ones, new ones, portable ones, but we're not seeing a lot of trained sonographers. And also in this time, how do we support other partners, even with the COVID-19 pandemic? There are resources that are needed education-wise for ultrasound and COVID. So this is just an example of some of the resources that RAD-AID has available, as well as some of the articles and videos out there, free source, that we've been sharing with our in-country partners. So what are some of the challenges that we observe with ultrasound in the developing world? Definitely a lack of standardized education, rare certifications, and those that are there without clear validation, poorly functioning and outdated equipment, lack of infection control. There are definitely unique social and cultural considerations, as well as voluntourism, which I'll talk a little bit more coming up. So in the lack of standardized education, this comes from the lack of few to no formalized training programs. Most of the folks are on the job trained. There's a wide diversity of learners. Often pay is not equal to their skill set or knowledge. Anytime we present a problem, we always want to talk about solutions. So in this scenario, we're trying to create curriculum to help, based on the needs of that hospital, create sustainable teaching through our consistent volunteer streams and trips, and to foster and encourage the importance of standardized education. Without certifications, what do we run into? We're not sure how these folks are trained. They can't really, they lack a foundation with a broader and deeper understanding of the modality. There's a difference between making an image versus understanding what you're seeing. It makes it hard for them to build professional credibility, and without a way to certify, it's hard to know. So we're working to standardize education. We're working to help establish standards of practice in ultrasound, and promote and elevate our global ultrasound partners, empower them within their communities. Equipment, it's not uncommon to see donated units beyond end of life. It can be very costly and time consuming to donate these. They often don't have warranties. Sometimes they don't have DICOM, often 1 unit for the entire institution. They lack probes that are needed. So we like to help educate our partners, help with materials, connect them with servicing organizations, encourage education about warranty and service. And we even have units to loan to our RAD-AID teams for travel. Infection control, definitely a big one. Either lack of understanding about it or just a lack of resources to have a sustainable infection control program. When you're looking at challenges with access to clean water and proper hand hygiene, you can see how infection control could be difficult. So we're working to help create awareness, provide education, help them establish, sustainable streams to get the materials that they need, and just to gain just in-country buy-in about the need for it. And then other unique social and cultural considerations, definitely they can go beyond the delivery itself. You know, what is the family background? What are the religious implications? An intimate examination may differ between patients. It may impact who the provider can be. The gender may be relevant. It may impact our teaching methods or what we might wear. So we're doing thorough assessment of the region and needs, trying to maintain appropriate respect for the healthcare boundaries and the cultural norms. So we educate our volunteers about expectations. Voluntourism, so an emerging trend linked to doing good. So sometimes folks that are traveling have limited skills and limited ability to change systems. They're using precious resources in the communities already, providing a false sense of help or change. If someone's there, they assume help is there. So through our assessment, we figure out exactly what is needed. We have a scrupulous interview process and make sure the folks going can do the most good and be the most helpful and provide expectations for how to manage differences on the ground. So these themes seem to emerge in regards to where help is the most needed. So educating, understanding our audience, what do we need to do? If we can't always be on the ground, how do we help still? Independent learning, hands-on, on-site, remote. How do we support with equipment? How do we bring good volunteers and educators to the forefront to help us? And how do we increase this network? Like the folks that are on the presentation today listening, hopefully we can build an even bigger network of folks to help us. So let's talk a little bit about the term point of care ultrasound. I think we've got a poll now we're going to throw up. So the definition currently is point of care ultrasound can be defined as the use of an image-producing ultrasound device for diagnostic and procedural guidance at the point of care in real time, allowing for direct correlation with signs and symptoms. It's ingrained in the clinical work and may increase accuracy of diagnoses or aid procedures, as well as reduce time spent to diagnose and decrease overall cost to the patient. So I'm curious what you guys might think about point of care ultrasound versus diagnostic, and do you see a difference? So I think we've got a poll, Madeline.
Yes, poll is running and it looks like 30+ of you have voted, so get your votes in.
So while you guys are working on that, I just wanted to talk a little bit about I think for me, point of care ultrasound and diagnostic ultrasound are different things, but they also have a lot of similarities, a lot of the same challenges. So typically point of care ultrasound is done at the bedside. We're trying to answer a focus question, a binary question. Are there gallstones or not? Is there fluid or not? Sometimes the images that we take are not archived. The clinician interprets, right at the site of the patient, and also will use this information to influence intervention. Some of the pitfalls, maybe we're using ultrasound type that we shouldn't. Maybe the patient acuity or their habitus impacts our ability to do that. Maybe working on the machine, we can't really optimize windows in the way that we'd like. Maybe there's a limited ability to recognize or rule out pathology, depending on the operator, for this idea of phantom scanning, where we're going to scan and then we're going to relay what we saw to the next person, but really not a way to document or go back to that. And sometimes no review by a specialist. But the bonuses to this being that it's something we can do really quickly, a really acute setting, get a fast answer so we can move forward, definitely in an acute scenario, or a patient that's stable. We just need to figure out how to triage. Diagnostic ultrasound, a little bit different, typically evaluation of a formal organ system. These images are archived, documented, formal dictation that mentions the indication. Most of the folks doing ultrasound have formalized training programs that are accredited. But some of the pitfalls there as well. Sometimes we can over rely on the image. We'll see something in an image, but the clinical picture doesn't line up. Also, sometimes that same patient habitus can impact our ability to do what we need to do. And sometimes it's used in a way that it's not always indicated. So I just wanted to bring up a patient venue here, basically just a patient present scenario. So a 51-year-old female, congestive heart failure, male, congestive heart failure on dialysis, had a mechanical mitral valve replacement, currently on warfarin. They're presenting with shortness of breath. They can't hear their mitral valve click anymore, which they normally could easily at bedtime. Physical exam, things look good. Vital signs are normal, lungs are clear, no murmurs, extra heart sounds, no swelling in the legs. The diagnostics that they do are pretty, they don't really show anything. They don't really explain what's going on. They just it's a nice stable patient, did a POCUS cardiac ultrasound, felt like their ejection fraction was stable, maybe some signs of volume overload, and they saw the mitral valve and felt like it was in place and working. So to describe volume overload, often we're looking at multiple areas to make that designation. We're not really looking at extensive review of valves in a POCUS setting, but we still can't explain the shortness of breath and the lack of click. When do we order a formal echo? In this patient, they were stable and it wasn't necessarily indicated. So they were evaluated to see if admission was necessary. The hospitalists had the same findings, no further diagnostics done. They felt, let's just dialyze them, they're volume overloaded. So they went home, they felt better. But they returned 12 hours later, critically ill and cardiogenic shock. Now this time, because of the acuity, a formal ultrasound was ordered and they found a thrombosed mitral valve leading to stenosis and the cardiogenic shock. So now it becomes a much more acute situation. Central line, pressors, they needed that mitral valve replaced. They were in the ICU and then to a SNF a week later. So in this setting, which was more appropriate? POCUS ultrasound, formal ultrasound, it definitely makes sense what was done and what the findings were and how it was handled. So it comes down to a clinical decision about what's best. Looking at anchoring bias, we assume fluid overload. This phantom scanning where we passed information from one provider to another. So making sure things like a formal note, images are archived, and that the clinical picture warrants which study that we're using. And in a scenario in the global health world, we're doing something sort of in between point of care and diagnostic. It's based on what's needed. You want to give the highest level of care that you can, no matter where you are. But if it's the difference between 10 patients or 60 patients, and you have one sonographer and one machine, you're going to have to make some decisions. So if you want to get involved, you want to provide education, how do you do that? You can't just show up. So how do you get involved? It seems if you want to travel and get involved to do ultrasound or provide education, that's either going to have to be through a government organization, an academic institution, or for a profit or nonprofit organization that can travel abroad, that has the on the ground relationships and stakeholders. So a lot of the things I'm going to show you are based on my experience with a nonprofit called RAD-AID International. It was founded in 2008 by Dan Miller at Johns Hopkins. We've been going for over 10 years now. Our mission is to improve and optimize access to medical imaging and radiology in low resource regions of the world for increasing radiology's contribution to global health public health initiatives and patient care. So they all have different structures, different leadership structures. We like to synthesize regional and operational expertise to form program strategies. So as you can see here, ultrasound is one of the operational teams that support our regional leaders. And I have an example of some of the programs, some of the countries that we're working in right now. So we support each other as operational leaders, as well as our regional leaders. We're proud to be recently recognized, or fairly recently recognized, as a designated UN-affiliated NGO. This allows us to really get boots on the ground and really be involved in policy and support in a global way. So where are we working, you might ask? So this map basically demonstrates many of the areas where we have programs. This is obviously growing all the time. So more than 35 countries, more than 55 hospitals. So you can definitely see we're spread out, and you'll even notice that we're here in the US. Our volunteers, we're a volunteer-driven organization, and currently we have over 11,000 volunteers. They come from a very diverse background. You can see the breakdown here. Predominantly, as of 2018, the majority of us are rad techs. You can see sonographers and physicians doing ultrasound, as well as IT, nursing, and other educators. And when we have applications for volunteerism, it's interesting that we get quite a bit of volunteer applications, globally. And we have a pretty big interest in volunteering from our counterparts in Africa. So I think this is a very interesting slide showing that as we educate those globally, we'll also have more volunteers to help educate globally. And then we have very strong partners. We're very happy for. You might recognize some of the names here, but we definitely couldn't do what we do without them. So where are we working? Where are we doing ultrasound? I don't have them all listed here, but these pictures highlight Liberia, Cape Verde, Haiti, Ethiopia. You can see all of these are really bright and shiny volunteers here offering their time. Just to go over a few of the countries that we're working and some of the problems we noted and how we address those. So RAD-AID India, we have a long-standing relationship there. We noticed large gaps in women's health, high cancer mortality, and we did find advanced tertiary care centers, but with marginalized periphery. So, how do we bring the need to those who can't make it to these tertiary care centers? So we partner with Phillips Foundation, a local academic institution, RAD-AID. We created this mobile strategy. So we're bringing this truck to the neighborhoods. You can see the women sort of lined up for care. We're screening for cervical cancer, breast cancer, and osteoporosis. And to date, more than 20,000 women have been served. There are pipelines to refer these women when we found concern for cancer and treatment. Another one of our projects, longstanding, is the Lao Friends Hospital for Children in Laos. Our readiness assessment there just demonstrated they had little equipment, little trained radiology personnel, lack of radiation safety measures, and no digital networks. So we came back to help. We helped establish a radiology department, bring in ultrasound, bring in x-ray. We've had volunteers going 3, 4, 5 times a year for years now, training the nurses and staff, the physicians on the use of ultrasound. Recently expanding our partnership to a local hospital there, an adult hospital. So now allowing our pediatric counterparts have access to CT. These are some of our volunteers teaching there. RAD-AID Guyana, similar theme, suboptimal ultrasound, scarce CT, no health IT, no radiology residency to help grow radiologist presence there. So we were able to donate ultrasound, we were able to bring CT, we were able to start a PACS, and we started a radiology residency there at Georgetown Public Hospital. These are some of the images of those residents. They were able to actually create an exchange program to come to the US and train with the radiologist here. They actually joined our RAD-AID, our international conference, in 2017. Tanzania, another slide just talking about disparity, just getting the comparison between staff available in Tanzania versus the US, radiologists, radiographers, sonographers. Again, a 50 to 100 times disparity. So here we've learned the concept of linking sites for imaging and treatment, pulling folks from one institution to another to receive group education. More than 52 volunteers since 2015. And currently we're working to help bring a formal ultrasound training program here. And then there's also opportunity to work here in our backyard. So we've done work in North Carolina, Virginia, right, Appalachia is the example I have here. There's an event they have yearly in a rural area of Virginia where folks come for free medical care. It's a 3-day event. Specialists from all over the US come and folks have access to care. Definitely something that we want to support, even in our low resource regions here in the US. RAD-AID Kenya, definitely a women's health need there, coming in, providing education about women's health, intervention, helping with equipment. So you can see the themes emerging here that we talked about. Peru, same, incomplete referral networks, non-functional mammography, limited ultrasound. So providing ultrasound education. We even have some AI projects ongoing through Peru right now looking at breast lesions. So really maximizing the technology available to us. Pediatrics, little ones everywhere. Pediatrics requires specially trained folks, especially special equipment, special needs. So we have a strong pediatric program as well. Ultrasound and IR, it's one of our really popular programs right now. I can see some of the images here of being on the ground. So teaching residents, physicians, interventional procedures that are less invasive, safe, having a big impact. So leveraging themes and capabilities is definitely something we're working to do. So taking the need that we have in India and the mobile truck and using that same theme here in DC to provide women's health support in the way of mammography to women who don't have access. this sort of meeting event where all the patients come to the care that we have in India, now using that same and working and supporting that same concept in RAD-AID Appalachia. We need IT, we need PACS. How can we store images so that when patients come back, we have a comparison? How can we review images remotely for folks to provide support? So we have partners here as well that are helping us install different or various types of cloud PACS scenarios. And again, looking at leveraging themes, bringing healthcare, bringing ultrasound to the need. This is one of our really exciting projects as well. I don't know if anyone has seen this. It's something I hadn't heard of before, but we have had a kind donation of this airship, and we're working right now to figure out where this will be used and how it will be used. But it basically eliminates a major challenge of airport road prepared infrastructure. We can essentially land where the need is, and you can see in the image here that there will be different little clinic pods, modules where we can put ultrasound machines or X-ray machines, whatever may be needed. It can be deployed in the field, can be used there. Even times in emergency, we can bring supplies. So this is an exciting thing that's developing. Definitely takes time, but it's there and we're excited for it. So hopefully you're all excited. How can I get involved? I want to go. So how can you get involved? So be a part of a team. Apply for a project, join a chapter. So let's talk a little bit more about that. So what do you want to do? What is your strength? Where do you want to go? Do you like to teach? Do you want to problem solve? Do you want to find a messy room and turn it into a nice PACS reading station? Do you want to innovate? Do you want to figure out a way to bring the care to the patient? We all have different strengths. Where do you want to go? Where do you want to do work? These are images from all over the world with volunteers. How do you apply? So we have a formal application process. There is a link on RAD-AID's website to apply. Once that application is filled out, it's reviewed, and we set up a formal interview via phone with one or more of our team members. After an interview, we review that interview information. We determine eligibility for a project. We connect you with the team that most needs you and your skill set. Depending on the funding stream, we'll have applications for that. And then we process your paperwork, get your flight set up, make sure we get you to the travel clinic. We'll coordinate everything on the ground for you in regards to lodging and support. We'll onboard you, get you ready for things. So this is sort of just kind of an overview of that process. What support do you have as a volunteer? These are images, again, of more of our volunteers. These are funded opportunities. These are some of our funding streams. They're supporting multiple modalities, and we're working across all country programs. Join a chapter, be part of a chapter. So a chapter basically tends to originate from an academic institution. The radiology residents drive these quite often. They have physician support, technologist support. Some of them are even technologist driven in total. But these are examples of chapters. So Dalhousie and UNC working in Malawi, Nicaragua with University of Wisconsin, Tanzania, New York, Yale. So get involved with these. And if you don't have one at your institution, start one. We're happy to help you start those. So you can see currently we have more than 72 RAD-AID chapters across the US. So it's another great way to get involved. Just kind of alluding back to support. So ASRT is one of our great partners, have been with us for a very long time, providing these outreach fellowships or scholarships for folks to travel and provide education. My first trip to Haiti was supported through ASRT, and I'm very thankful for that opportunity. And most recently, for those applicants who've experienced a more financial or career-related challenge from COVID-19, they're showing preference to get these folks opportunities and get them out there. What makes a good applicant? We want you to have a strong fund of knowledge in the modality or technical specialty. We want you to be able to travel if possible. We need someone to be pretty flexible in a constantly changing environment and project dynamics, adaptability to the learning styles of the folks that you're educating, sensitivity to cultural and societal norms that we already alluded to. We need someone to be a team player, and we're going to give you predetermined goals and objectives for the project to adhere to those. So these are volunteers we have in RAD-AID in Virginia and then in Ethiopia. What resources are available to you as a volunteer? We have put together country reports for the area that you're going to be in. You'll have prior trip reports for those who have gone before you. So the handoff from the prior volunteer to help with the sustainability of the project. Travel clinic support. you can find literature about global health radiology. So here I sort of highlighted the textbook like we're studying. So you can already see topics: mobile strategies for global health, women's imaging, ultrasound, and global health. So places like these are great resources for volunteers and for anyone interested. Common questions asked by volunteers: how long will I be away from work? Is it safe? What if something happens? Do I need vaccines? Who will be my point of contact? So we will take care of all of this for you. We have all of this sorted out already. So either the prior volunteer will hand that off to you, or that'll be provided to you in the country report. So with each country, each project, it varies. Come to our RAD-AID conference. Well, I guess this year you'll have to attend virtually, but it's at the Pan American Health Organization offices in DC. A lot of great minds, folks with ongoing projects, folks that want to get involved. So definitely join us. It's a weekend event. So for our teams, the expectation: education, on-site, hands-on, customized based on assessment. We can make materials available to your learners before you arrive. Troubleshoot, assist with the equipment challenges they may have, help to build networks, establish relationships that can be lifelong. And the really big point to make here is sustainability. It's so important to have sustainability. When we get on the ground, we want to establish a relationship. We want to continue to go back. And our goal ultimately is to empower that community so that they don't need us down the road. But it's so important to stay there, stay involved, keep folks on the ground. And when you're looking at sustainability, you've got to base your decisions on the data you have, specify who you want to serve, what your goals are, actively pursue the necessary resources, and consider what is working with other organizations. And lastly, I wanted to just touch on that sustainability concept. Can we bring ultrasound certification to the point of care? And how do we do that? We're going and providing education now, but how do we keep that going? How do we educate those on the ground to the point that they can obtain their own certifications and educate their future employees? Just some ideas that have come up as we're thinking about this concept. We're finding gaps in all specialties and all content areas. When we build education, it has to be unique. We want to be hands-on as much as we can, but when we can't, we're going to have to do a good bit of that online through webinar. We're going to have to teach folks how to test. Maybe folks aren't familiar with the strategies behind taking multiple choice exams. We're going to have to provide sample tests for them to get used to that as well. How do we test? How do we certify? We're going to have to use unique testing methods, hands-on exams, clinical case scenarios. If a patient presents, can we even provide a certification for them, like a digital badge like we have here in the US? So one of those programs is now in pilot stages that we partner with Intelios to start or initiate a midwife skilled birth attendant education program. So there's information here. I'm happy to answer more questions about it after the talk, but this is up and coming. And so it shows that we're now starting to try this concept. So I've got a video I wanted to share with you about our volunteer work.
Hi everyone at RAD-AID. I'm Matthew Schwartz. I have always had a place in my life for volunteerism.
Hi, my name is Kirk Stonick. I volunteered through RAD-AID at the Lao French Hospital for Children in Laos.
My name is Christina Hendricks, and I'm a sonographer at the University of Wisconsin Hospital and Clinics in Madison, Wisconsin, and I've been involved with RAD-AID since 2015.
I chose to volunteer with RAD-AID.org to help educate and teach ultrasound to those with minimal access to tools and resources needed to provide improved patient care. The desire to serve others has been foundational to my personal mission, and I found alignment with RAD-AID on this goal.
It is important to me to be able to give back to my community. And as a sonographer, my community is fellow sonographers as well as other medical professionals who are incorporating ultrasound into their practice.
I was drawn to the idea of volunteering my time and skills, but I struggled to find any local organizations that utilized sonography on a volunteer basis. And then a few years ago, I received an email to our ultrasound group at our hospital about a local RAD-AID chapter at our institution. And while I was interested, I assumed I wouldn't have enough experience, there would be too much interest for me to be considered for a trip, and so I didn't pursue it. After hearing about another informational meeting about our RAD-AID chapter, I decided that my desire to volunteer far outweighed my self-doubts, and I went to the meeting, got involved, and started helping take over our RAD-AID chapter, and then planned our first trip to Nicaragua.
I volunteered the first time because I love to travel, and I thought, what a great opportunity to combine travel with being able to help people and be a part of the culture of where I'm going. To me, the most fulfilling trips have always been where you're not just an observer on the outside, but you're actually participating in being with the local people. And volunteering with RAD-AID was all of that. It's the most fulfilling thing.
So I've been working as a sonographer for around 7 years, which is something I absolutely love to do. And I'd always been interested in the idea of global health outreach for pretty much all my working life. So at that moment, it seemed to be a great opportunity to bring together those two things and to try to volunteer some of my time and also to just challenge myself to do something new in my career as well. So after a little bit of research, I found out about RAD-AID International, and it seemed to me to just be a great organization doing some fantastic work, and their aims and ambitions were aligned exactly with what it was that I was hoping to do.
Being able to step out of one's own experience, change one's perspective, and to be able to appreciate the parameters in which other medical professionals are practicing is eye-opening and essential, I believe, in both our practice here in the United States as well as volunteering abroad.
So we really quickly fell into this pattern of teaching and learning, which meant that by the end of the trip, we'd both had this sort of reciprocal learning experience, which the team there tell me worked really, really well for them. And I certainly felt like I learned so much from them, and they were so generous with their time in teaching me that I would definitely say that that is the most rewarding part of my trip overall.
People are just constantly teaching and consulting each other there and interacting outside of their primary work group. I would have doctors and nurses, lab techs, English teachers, what have you, come to me and pick my brain about something and then offer up their own wisdom or knowledge on something else. And I mean, there was such a culture of teaching and learning there that at almost any given time there would be a class happening upstairs where one of the local staff or one of the volunteers would just be giving a case report or teaching something new. And the investment of all these people and groups in the place was infectious. And so my excitement to go to work and to participate in it just grew and grew as I was there.
The largest challenge I found during my experience was wanting to do more, help more, and serve more. With global health, it takes time, patience, and repetition to make educational steps forward, and it was a challenge I think I could only have experienced personally.
But sometimes it was hard. I mean, despite all the love that LFHC receives, they are still lacking quite a bit on funds and equipment. And local patients, it's so common for it to be very hard for them to get to the hospital that frequently people would show up who would just be not in great shape. And the investment of the staff and volunteers and these patients meant that the joy of the group would come up so high when a patient would make it, and then we'd have plenty of people who would pass away, and then just the whole group would just feel really sad and down about it, which of course is emotionally hard, but it's also incredibly rewarding. And I mean, it was just an absolutely wonderful experience for me.
I first went to Tanzania in 2016, and definitely the most rewarding aspect of my trip was seeing the aha moment in many of the individuals with whom I worked. Seeing them make connections between facts and concepts that they were familiar with and being able to apply them in a new direction, in a new capacity, and the joy of that light bulb going off is incredibly rewarding.
And once I went on a RAD-AID trip, I realized that this is really a way to give back and really help. And you don't really realize until you leave this country how much other parts of the world really need. And the best part about coming back is that after you're back, it's contagious. You tell everyone you work with, you know, what a fulfilling thing it was, and gets other people excited, and they go too.
The most rewarding part of my experience is the lasting connections that I have with the sonographers and hospital staff I help teach while in country. These relationships are based on the desire to serve others and provide a high level of fulfillment for me, and I look forward to building and developing these relationships in the future.
That I think was the most rewarding part of my experience overall, I would say that it was that I learned as much as I was able to teach. And I feel like I came home a more knowledgeable and a better sonographer than when I left.
I can't say enough about what a phenomenal experience it is to go to a country where they really need the help and give back. And it's not only them you're helping, it's the best thing in the world for you too. Like, it just warms your soul over and over.
And it was honestly just one of the best experiences of my entire career.
We have a wonderful profession, and the passion of others to share their unique skills is inspiring.
All right, guys, so we need all of you. We need everyone to get involved and help all kinds of sonographers. As you see here, the needs are great. Physicians, IT, IR, we need everybody.